Good evening, everybody. We're going to discuss the potential use of hypertonic salines during the treatment of sepsis. Why should we look at hypertonic salines during sepsis? Well, we've just seen crystalloids have a low expansive impact and to heighten the plasmatic volume as there are going to be some leaks we're going to lose in terms of efficacy. We've also seen that colloids have not displayed that they were more effective regarding prognosis for the survival of patients. Synthetic colloids have side effects. There are others which are banned in Europe and the United States in intensive care. We've spoken about gelatines. They've never been assessed. There's not been any study. And the trials on albumin are relatively disappointing, even though Jean-Paul has told us that there's a trend towards an improved survival rate. Nevertheless, we're disappointed. Hypertonic salines were mainly used for the treatment of trauma injuries, brain trauma, with lots of positive impacts which have been shown in terms of reducing these brain edema, reducing intracranial pressure. But there are other impacts that have been seen in that category of patients with positive impact on vasoresponsiveness, on more effective expansion, with a positive hemodynamic impact, which contributes to better perfusion intracerebrally, and immunomodulatory impacts that may be of interest during the sepsis. During the meeting of the FDA, the goal of which was to reassess the risk-reward of hydrocetyl starch cell solutions during sepsis, the issue of possible alternatives to use if one were to ban them with patients in intensive care. Well, the suggestion was that the positive impact of hypertonic salines on polytraumatized patients, well, the clinical trials are quite disappointing in that population, and suggested that perhaps one could test the hypertonic salines in patients, in septic shock patients, which had not been treated in this way before. I recall that there are different types of hypertonic saline solutions with varying degrees of concentration. The most used are the high hypertonic with at least 7%. More often than not, they have been assessed in conjunction with a colloid. There are a few studies that looked at the hypertonic crystalloid, non-associated with colloids, but there are also less concentrated solutions at 3%, 4%, 5%. None of them are commercialized in France, so France has never looked at these closely, even though they're available in other countries. I recall the mechanism, the expansion capacity. When you increase the intravascular capacity, there is going to be an injection of fluid from the endothelial cells, and red globules, red blood cells or white blood cells, and it was perhaps good to have less of an edema. Sodium chloride was circulated through the interstitium, which attracts liquid by intracellular channels, and this will go back into the plasma through the lymphatic system. In theory, we should have an expansionary capacity much higher with hypertonic crystalloids, approximately 3 times more or 8 times more for the doses of in excess of 7%. That's the theory, but that's not necessarily what we come across in practice. Potentially, there is a dual effect, and favorable, positive hemodynamic effect, even though there's an inotropic impact, and an impact on vasoconstriction, and there are also anti-inflammatory immunomodulatory impacts. In terms of the expansionary capacity, there have been few studies. This is an old study that was conducted in anesthesiology on parents with peridural, with 3 solutions, 2 isotonic crystalloids and 1 hypertonic with a 5% dose. The goal was to have the same arterial volume. It was done on a blind basis, and in this study what we find is the required volume, which is 5 times less with hypertonic at 5%. But this does not apply to all studies. This concerns patients for cardiac surgery, but in post-cardiac surgery, this is a slightly more sophisticated methodology. We were looking at the volume of plasmatological increase with the same dosage, or with normal saline or hypertonic saline, and you see that the maximum increase achieved in plasmatic volume shows no difference, no such difference. We have 400 milliliters with the normal saline and 550 milliliters using the 7% dose of hypertonic saline. We don't have much information or data on the impact of the fluid injection. There are positive inotropic effects which have been described with the use of hypertonic salines. In other words, when we have myocardial cells with a 60% concentration, we improve contractility, myocardial contractility. And what's interesting is to look at the potential mechanisms. But in amyloride blocks the exchange of potassium at the membrane level, and you usually impact on inotropism, and it's probably linked to the potential of the membrane. There is also an aspect on the myocardial factor which is shown in the study. This was mannitol which was used. It's an ischemic myocardial model, and what the authors found is that in the impacted areas with the use of mannitol, there was less of a myocardic edema, less of an endothelial edema. Here you see the capillaries which are exposed to an isotonic saline. You see significant edema, which you don't see in the capillaries when mannitol has been used. So that could potentially contribute to a better inotropic effect. Filling a patient with a hypertonic saline also creates osmotic stress, and this appears in the study. It may increase the secretion of vasopressin and could have a vasopressive impact. And we see that the animals that were being administered these fluids, either in isolation or with other fluids, showed a higher sodium concentration, but at a higher level of vasopressin compared to colloids. And what is interesting here is that in this study, when you look at animals, when the animals had receptor antagonists, this inhibited the impact of the hypertonic salines on arterial pressure, and the arterial pressure does not increase with hypertonic salines, which suggests that there is a role on the secretion of vasopressins, which in itself could heighten vasoconstriction. So that was for the positive impacts. There are also anti-inflammatory effects which have been described regarding cytokines and the activation, endothelial activation. This is a model used on animals with a blood hemorrhage shock, the emergence of pulmonary lesions, and also the activation of the polynuclear activation when the animals undergo intensive care. That's using with a 7.5% dose. We see there is less polynuclear activation, and this leads to less of loss of albumin, and there is also less neutrophil in the liquid and polynuclears that are less activated. What is interesting is that the beneficial impact was found in less hypertonic cyanines, with 3% hypertonic cyanines in this example. In red, you have the 3% dose. In the grey area, 7.5% dose. And you see that there is an impact on the production of TNF on IO6, which is identical whatever the hypertonicity of the products. And the animals who had been undergone intensive care had fewer pulmonary lesions after the intensive care using the hypertonic salines on a 3.5% dose or 7%. But as usual in medicine, the studies don't always come to the same conclusions, and this is the work done by Antoine Roque in Marseille, who also looked at the pulmonary inflammation using hypertonic salines during the IC to treat hemorrhage shock. He did not find any positive impact using saline hypertonics, and the same applied to pulmonary inflammation. There was no difference. So what may account for the differences that we find in the different studies and models is the administration method of hypertonic salines. This always happens in the animal cases before we test the animal or after. It may change the results, and this is what this study sought to prove. It's a peritonitis model, where you can see that there's a group of animals in which the hypertonics were administered before generating peritonitis, or after 50 or 1 hour later. And the authors looked at the polynuclear activation, and you see that the positive impact emerges when the hypertonic salines are administered before the sepsis, and if you administer them after the sepsis, then you lose the efficiency. Even 1 hour after, it can produce negative consequences. So why? This is Unger's work, who sought to understand the impact of polynuclear activation. The mechanism that is described shows that there are two opposite impacts depending on the impact of the receptors. If we're looking in particular A3 receptors, that will increase degranulation of leukocytes. If it's A1 or A2, it will reduce degranulation of leukocytes. And what we've found is that hypertonicity in itself can increase the receptors to A3.
What we see here is when you give hypertonic fluid, so before you stimulate polynuclear, A3 receptors have not expressed themselves yet, so you can have an impact of degranulation, but after stimulation, the A3 receptors have expressed themselves, and degranulation, however, is going to increase. And here we see this is a sub-study of a randomized study in patients in the hospital setting for a trauma, with a measurement of A3 receptors on polynuclears, and you see that they are poorly expressed on the most critically ill patients. So these patients, we know that A3 receptors will be overexpressed, and you might be losing a bit of the benefit of these fluids. Now, what do we have regarding human sepsis in terms of comparative studies? We have this study, which was basically hemodynamic. Authors compared these patients here, background hemodynamic. There is definitely a favorable effect on the increase of the cardiac flow, but it is basically due to the filling factor of hypertonics with fillings that were clear, but there was no inotropic effect that was clearly evidenced. Here, a 3-arm study comparing either a isotonic or an hypertonic solutions, and a third group bicarbonate, 30 patients per group. They get the same volume, 5 milliliter kilo, in all three arms, and cardiac flow, cardiac pressure is average. There is no real difference, the same volume, but no real difference in terms of the cardiac flow and the pressure. It goes up in all three groups in the same way. So, did these patients really get the hypertonic solution? Because when you look at what happens at the second hour, same as in the isotonic group. So did they really get an hypertonic solution or not, is a valid question. A more recent study, less patients, 12 patients per arm. They got 250 milliliters either of salinated water or hypertonic associated, again, to same practice before. Feeling is the same. Systolic injection volume is a bit better with the hypertonic solution, and there seems to be a correspondence between average pressure and the dosage. It seems to be evolving a bit better in the hypertonic group. In these patients, they did get hypertonic fluid administration in 5%. At half an hour, we're at 143. And it goes down again very quickly. It was just one dose of 250 milliliters that was administered. In the same study, they looked at the effects of hypertonic fluid administration on the gene expression of inflammatory mediators in circulating leukocytes. So for some markers, hypertonics are better, for others not as good. So not easy to draw any significant conclusion from that. And cytokines, not much difference, but it was only, as I remind you, as I told you, 12 patients per arm. So, in conclusion, what is the role of hypertonic saline? Well, come and see us tomorrow, the last session of the Congress. We'll look at the large multi-centric studies, and we'll look at hyperoxia and also at the hypertonic saline solutions. That will be in Etude study hyper